इशारा कर देना लाइव होगा तो। Good afternoon, everyone. On behalf of Corona Remedies, I, Tushar Tuhi, take this opportunity to welcome respected speaker Sir Dr. Jai Shah and welcome all esteemed delegates to Rhythm and Wave Masterclass on topic novel patterns of ischemia and STEMI equivalents. ECG has always been a handy, non-invasive diagnostic tools for clinicians, helping them to diagnose cardiovascular diseases and hemodynamic states. Accurate interpretation of ECG helps in clinical decision-making process and crafting treatment strategies for better outcomes. Now, let me take this privilege to introduce our esteemed speaker, Dr. Jai Shah. Dr. Jai Shah, who is DNB in medicine and DNB in cardiology, having FACC, FESC, FSCI, and is a senior consultant cardiologist in Ahmedabad, having more than 20 years of clinical experience. Dr. Shah is director and founder member of Ananta Hospital, Ahmedabad, and head of Department of Cardiology in HCG Hospital in Ahmedabad. Recognized for his academic achievement and expertise in advanced cardiac care, specialized in complex coronary interventions like PAMI, bifurcation stenting, multivessel stenting, and CTO. Dr. Shah also has a keen interest in imaging assisted angioplasty such as IVUS, guided PCI, and complex coronary intervention. Numerous national and international publications on multivessel stenting to Dr. Shah's credit. With this, I would hand over the session to Dr. Shah to take the proceedings of the session ahead. Over to you, sir.
Thank you. Thank you so much, Tushar Bhai, for these kind words. At the outset, I would like to thank the whole Corona Remedies team and especially Mr. Neeraj Jain, Vijay Charlu, and Jayesh Vyas, who has given this particular topic to me. Not only that, they've started with something like this, which can be useful to so many consulting physicians, because by having good knowledge regarding the ECG, I'm sure that you will be able to diagnose so many conditions on time, and by that you can benefit your patients in real time. So let me start with the understanding of this particular topic. And this topic is basically a ECG, where we need to identify some of the equivalent of STEMI. STEMI means ST elevation myocardial infarction, and which are the novel patterns of ischemia. That is what we are going to study in this particular talk. So when we are looking at the STEMI, the new ST elevation at J point in two contiguous leads with cutoff points are 0.1 millivolt in all leads other than V2 and V3. That is the diagnosis of STEMI. This is a new classification. It's a third universal definition of myocardial infarction, where they've given this particular classification based by ECG. In V2 and V3, the following cut points they are going to get applied. So when we are talking about male and female, there is two category: male less than 40 years of age, male more than 40 years of age. Because in young patients, even if the voltage is going beyond 0.2, and preferably if it is going more than 0.25, that is where you can see that, or you can count that as a ST elevation. While in case of women, the criteria is still more stringent. It is producing 0.15 millivolt in female, which is suggestive of ST elevation. And this is the J point or the ST elevation, which you can see or observe for this particular ECG. And the statement is being given as a, I'm sorry. Yeah, as a part of, I'm just searching for the color. Yeah. So this is the pointer. This is the J point. And this J point is getting elevated. And that is the sign of a ST elevation MI. Now, in V2 and V3, there are certain patterns which we must understand that they can be there. Less than 0.2 millivolt in male is considered to be normal, but in cases where there is an early repolarization, or you can say that there are chances that you might have a normal variant which can be present even if the voltage is going more than 0.2 millivolt, but they are not considered as acute MI or acute ST elevation because they are the part of either a normal ST segment elevation or a early repolarization, or even a normal variant. You might see even a biphasic T waves. Now, this type of pattern, you can assume that the patient might be having some myocardial breach, or there might be a little sluggish flow in the coronary arteries. Even though the coronary arteries is normal, patient is not having any major occlusive stenosis in the artery, still you might find this type of STD changes, but you must remember that this could be a normal variant unless it is fitting into the criteria of ST elevation. Now, before we are going ahead with that, let me take you to the actual classification of ST elevation. Before that, you need to understand what is the level of anterior wall MI and which are the leads which is favoring anterior wall MI, which are the leads which is favoring inferior, and which are the leads which is favoring lateral wall MI. Now, in anterior wall MI, you can see that from V1 to V4, or rather V6, it is showing the anterior leads. Inferior means 2, 3, and AVF, while in lateral or the apical lead is 1 in AVL. Sometimes even a V5, V6 can also give you the diagnosis related to the lateral wall myocardial infarction. Considering the inferior part, 2, 3, and AVF, these are the three leads which can give you the idea about the inferior wall. Well, now you can assume that the inferior wall is by and large connected with the right ventricular free wall involvement in almost 70 or 80% of the cases. While there is a inclusion of even a posterior wall, which is further potentiated in in another 10% of the cases, where you can get V7 and V9 leads, which are being there as at the back side of the body, that is at the level of scapula. These are the V7 and V9 leads. While in case of right-sided leads, you can see that it is right ventricular or RV3 and RV4 leads, which are representing free wall right ventricle. So this is how you can diagnose the elevation of ST segment in this type of ECG, where you might see even a ST elevation. Why it is important? Because time is muscle, and emerging interest will be there to diagnose whether the patient is having ST elevation MI or not. And ECG changes do not fit into the classical criteria. You can say that once you are able to diagnose STEMI, you can treat that condition in near time, and you can prevent that patient to develop muscle damage. And that is the reason we need to identify which are those STEMI equivalents. Because otherwise, acute MI, routine ST elevation, I'm sure that everyone will be able to pick it up. But which are those STEMI equivalent? Because these are the equivalents, unless you recognize them in time, it requires a very aggressive and definite sort of intervention. And these are some of the important points which are required to identify as far as the STEMI equivalence is concerned. And that is associated with classical ST elevation with an acute coronary occlusion. First of its kind is ST elevation in lead AVR, which is suggestive of acute left main coronary artery occlusion. Then comes Valence syndrome. Then comes D Winter sign, which is known as Widor's sign as well. Then there is a pathological ST elevation in LBPP, where you will be able to identify the Garboz's criteria. And then there is a posterior wall myocardial infarction. Now, these are the 5 conditions. They can be present as STEMI equivalent. So increase awareness about STEMI equivalent. It facilitates communication between physician and cardiologist. And if you do an early PCI, it will definitely help in improving the door to balloon time, and thereby you can improvise on the cardiac or the cardiovascular outcome for that patient. Now let us start with the case. Let me start with the first case. Here we are talking about a 55-year-old male having a chest pain, diaphoresis at night in emergency department, and you can see that there are definite some changes which are there in this ECG. Now, what is very striking to identify is that there are lead 1, AVR, V4, V5, and V6. They are definitely showing a ST depression and T inversion. But what is more striking is lead AVR. Can you see the lead AVR? Lead AVR is definitely showing a ST elevation. Now, this ST elevation needs a lot of attention because the patient is being responding to the nitroglycerin or a sublingual sorbate. Patient is being given or loaded with aspirin, clopidogrel loading dose, and started on heparin infusion. Patient was being stabilized with the help of medical management, and then he was subjected to receive therapy in form of pre-medication, and then he was being subjected for coronary angiography. But in soon before the coronary angiography, patient was developing a cardiac arrest within 2 hours and put on an IABP and inotropic support in ICU. Why is it? There is a condition by which this ECG will warrant that you must understand a very, very high gravity of situation, because unless you find this ST elevation in a lead AVR, you will not be able to diagnose the underlying condition, because this condition gives you the idea about the left main coronary artery occlusion. Here is the lead AVR elevation, and if it is there, it will lead to widespread ST depression in lead 1, lead 2, and in lead V4, V5, V6. Not only there will be an ST elevation in lead V1 and lead AVR, but here the lead AVR elevation will be more than lead V1 elevation. Now, these are the criteria we must remember. It is a diagnosis of acute left main coronary artery lesion, and this requires an urgent attention. Unless it is being treated in time, it can lead to cardiac arrest in form of ventricular arrhythmias or in form of sudden pulmonary edema, which can lead to hypoxia and even a ventilatory support. So whenever you see ST elevation in lead AVR, you can diagnose even a proximal LAD occlusion or severe multivessel disease. That means even a triple vessel disease can also be presented like this. Now, what is the mechanism? Why there is an ST elevation in lead AVR? ST elevation in lead AVR is because of the vector. Here you can see that the AVR is a cavity lead. It is going away from this, and this is the heart position. This is the vector which is going from below upwards, and AVR becomes positive because the acute MI or the reciprocal changes are being there on the opposite side. And that is the reason the lead AVR is producing ST elevation. The opposite leads, they are V4, V5, V6, and 1 and AVL, they are lying on the opposite of AVR. They will be showing a significant ST depression. That is the reason you might see a reciprocal changes in form of ST depression in those leads, while you will be able to see ST elevation in lead AVR. So the context is to identify whether the patient is having lead AVR elevation or not. If it is so, if there is elevation of more than 1 millimeter, it will indicate proximal LAD or left main occlusion or even a triple vessel disease. By and large, this patient will require urgent bypass surgery, because unless it is being treated in time, it can lead to cardiac arrhythmias, cardiac failure in form of acute pulmonary edema, and it can lead to acute left ventricular failure. So in context of anti-wall MI, if you do this type of ECG, or if for an example, if the patient is developing this type of STT changes while they are doing an exercise or TMT, you might see some such type of changes. You will be able to diagnose ST elevation in lead AVR, which is associated with 4-fold increase in mortality. And you can see that this mortality is getting increased once you are having more elevation in AVR. It can reach from 20 to 75%. And 30-day mortality rates, they are getting lower in patients, those who are having ST elevation in lead AVR, but they are being treated with the help of reperfusion therapy. So ST elevation more than 1 millimeter in lead AVR is a sign of left main disease or a severe triple vessel disease it requires urgent angiography, and because it is associated with increased mortality, so you require a high index of suspicion to diagnose this condition. Now, lead AVR is always considered to be an orphan lead because you don't see on that lead because it is almost always being neglected. So instead of neglecting that lead, it is always better to diagnose the condition from that lead. And which are those conditions which can be diagnosed just by looking at the lead AVR? They are left main occlusion, proximal LAD occlusion, triple vessel or a multivessel disease, acute pulmonary embolism, or arrhythmias in form of AV dissociation in VT, that is ventricular tachycardia, which is a life-threatening arrhythmias, or there is a presence of accessory pathway leading to AV nodal reentrant tachycardia, which is having a paraseptally located accessory pathway. Now that will lead to the wide variety of SVT with aberrant conduction or VT with AV dissociation. All these things might be having lead AVR elevation. These are some of the example. Here you can see that this ECG is very well diagnosed because of the left main occlusion. You can see this type of ECG even in a AV reentrant tachycardia in lead AVR. But apart from that, if the patient is having acute pericarditis, you might see PR segment elevation in lead AVR. And prominent R waves are being seen with elevation in tricyclic antidepressant poisoning. So those who are having antidepressant poisoning, they will be having a prominent R waves. So this is the ECG which is showing a elevation in lead AVR, depression in 2, 3 and AVF and lead 1. Apart from that, there is a depression of V4, V5 and V6. The diagonal, even looking at the lead AVR, you will be able to see the little bit of ST elevation. But here, the lead AVR is having little more ST elevation as compared to lead V1. So the diagnosis of ST elevation in lead AVR is indication of left main. But whenever there is a V1 elevation is more than lead AVR, it is going to give you the diagnosis of proximal LAD occlusion, proximal to the septal perforator, which is the first branch of left anterior descending artery. Or if there is a new onset RBBP or QRBBP, that is a sign or a diagnosis of a very poor prognosis of an acute MI, which can lead to sudden heart failure or even a cardiac arrhythmias or even a AV block, because here QRBBP is showing that the blockage is lying before septal perforator, which is supplying the septum of the interventricular body, and that has been blocked and it will lead to QRBBP pattern. Along with that, there are chances that the patient might be having a bradyarrhythmia or sometimes complete heart block. So these are the ECG. It requires a lot of attention and it requires a lot of timely intervention which can save the life of the patient. Coming back to another case, 63-year-old male in emergency department with a history of substernal chest pain or sweating 24 hours before. There is no chest pain on an arrival. Diabetes is there. Past history of smoking. On examination, patient is stable, but the ECG is showing this type of changes. Now, looking at the changes, you will be able to diagnose that the patient is having a biphasic T wave in V1, V2, V3, and V4. So this suggests that the patient is having some sort of ischemic pattern going on, and this is a sign which is known as Valence sign. It is a sign of proximal LAD descending left anterior descending artery lesion. And when we see the coronary artery angiogram, it is showing a lesion exactly at the origin of the left anterior descending artery. This is the left main artery, this is the left descending artery, and this is the left circumflex artery. And before the left anterior descending artery gives some septal perforated, the blockage is lying exactly at the level of ostia. So this is the sign which has been diagnosed by Valence. Professor Valence, they have diagnosed this condition in 1982. And after that, this sign is known as Valence sign. And the syndrome is the pattern of ECG T wave changes associated with the critical proximal LAD stenosis, which is referred as LAD coronary T wave syndrome. There are different types of T wave inversion. Giant, negative, deep, and symmetrical T waves are being seen in this panel B. and there is a biphasic T wave. All these changes are there as a part of Valence syndrome. Subtle T wave changes are being seen, and this type of changes, once you see, there is one thing which is completely contraindicated, and that is treadmill or a TMT. You should not undergo the stress test or a treadmill test for this type of patient. There are two types of Valence syndrome. Type 1 is biphasic T wave, which is there in 25% of the patient, and type 2, which is precordial T waves. They are deeply inverted with symmetrical contour, which is present in 75% of the patient. Now, these T wave changes are deep and symmetrical. They are suggestive of type 2 Valence syndrome. And this is which is showing a biphasic T wave. It is shown as a type 1 Valence syndrome. This valence sign is very commonly been seen in our routine clinical practice, and it is a sign of a proximal LED occlusion. Proximal LED occlusion definitely requires some intervention. Otherwise, it can lead to a sudden ST elevation, and it can lead to a transmural myocardial infarction, leading to sudden loss of myocardial damage, and there'll be a sudden reduction in the ejection fraction of the patient. So the key to Valence syndrome is a very steep, straight T-wave descent in one or more anterior leads, and much steeper than the downslope of the garden variety of ischemic T-wave inversion. That means it is giant, it is negative, it is deep, and it is symmetrical. All these things has to be there to diagnose Valence syndrome. Now, there are features which can mimic like Valence syndrome or STEMI equivalent, but they are not actually cardiac, like Valenoid T wave. This type of Valenoid T wave, which is seen or rather assumed as Valenoid syndrome, they are being there in the intracranial hemorrhage patient or a stroke patient. You can see that whenever there is an intracranial hemorrhage, such type of changes are being seen, and they are known as Valenoid changes or a Valenoid syndrome. So in nutshell, first we have seen ST elevation, STEMI equivalent with left main occlusion. Now we are seeing STEMI equivalent with ostial LED occlusion or a Valence syndrome. It is a pre-infarction stage. These changes are associated with the obstruction in the proximal LED. Early angiography and intervention is required, and treadmill test or stress test is completely contraindicated. So third part is a De Winter sign. This is again a STEMI equivalent. You can see that there are tall T-peak waves. They are having upsloping of ST elevation or J point elevation, which is being seen in V4 or V3, which is a sign of a proximal LED occlusion. 1 to 3 millimeter of ST depression that is upsloping at the J point in lead V1 through V6 is associated with persistently tall, upright, symmetrical precordial T wave, which is a sign of a De Winter sign. This is a first sign of a developing acute MI. First sign of a developing acute MI. It is known as De Winter sign or a widower sign, because patient can lose their life and you can make the wife of a patient widow. And that is the sign. It is known as De Winter sign. It is a tall, peaked or a hyperacute T wave, which is a sign of ST elevation, and it can lead to a development of mural, transmural acute MI, and it will require urgent intervention. De Winter sign, it is an acute proximal LED occlusion, while in case of Valence sign or Valence syndrome, you will always get some time because it's a chronic LED ischemia. In De Winter, you have to go for an urgent coronary angiogram and reperfusion, while in Valence syndrome, you can always go for an early angiography and elective PCI. This is the case of a STEMI. Fourth case, where you can see that there is definite amount of bundle branch block. Here you can see that the tachycardia is being seen. There is a M-shaped pattern in V5 and V6, which is same as lead V1 and lead AVL. So it's a M-shape, which is a sign of left bundle branch block, and patient is presented with STT changes in the V1, V2, and V3. That is showing chest pain and diaphoresis. Because he is diabetic, the changes are being seen in form of ischemic pattern. In patient with left bundle branch block or ventricular pace rhythm, infarction diagnosis is becoming very, very tedious. You require a high index of suspicion. You need to require certain criteria to be remembered, that this patient is falling into Garbosa's criteria. Now, these criteria are being diagnosed for left bundle branch block with acute MI, and they are being recommended to identify development of ST elevation MI in left bundle branch block patients. How can you diagnose? So there'll be here, this is a normal left bundle branch block, but in Garbosa's criteria, it will produce a discordant ST segment or T wave. That means the discordant ST segment and T wave, which is normal pattern, is being completely changed from LBBB to ST elevation. And in Garbosa's criteria, you will be having a pattern which is having a ST elevation, and the criteria is showing ST elevation. While in case of V1, V2, V3, it is showing ST elevation and showing ST depression in V2, V1, and V3. These are the criteria. They are known as Garbosa's criteria. Here there is a ST elevation of more than 5 millimeter. Here there is a ST depression of more than 1 millimeter. And here there is a concordant pattern of T elevation along with the QRS complexes. So these are the points where ST elevation of more than 1 millimeter, which is concordant, it has got a 5 point. ST depression of more than 1 millimeter, it has got a 3 point. While in case of ST elevation of more than 5 millimeter with discordant QRS is having a 2 point. So whenever the score is going more than 3, it is consistent with the acute MI. It has got a specificity of 98%, while the discordant criteria are list specific. That is the reason the ST elevation is showing in LBBB pattern, which is a sign of a presence of acute MI in presence of left bundle branch block. So you require to undergo definite revascularization. Early cath lab activation is required because otherwise you will be able to lose this patient in no time. So Garbosa criteria, if it is more than 3, it goes in favor of acute MI if there is an LBBB underlying rhythm. While in case of ventricular pacing rhythm, you will be able to diagnose the bleep. Can you see the bleep here? This bleep is producing a QRS complexes, and it is showing a great amount of discordant ST elevation, and it is showing a depression in the V1, V2, V3, which is favoring the Garbosa's criteria and giving us the diagnosis of acute MI. Now, the fifth and the last one, that is again a STEMI equivalent, which is showing with a case of 60-year-old male having an acute chest pain, having sweating. You can see that there is a ST elevation in lead 2, 3, and AVF, and there is an ST depression in V2 and V3. But when you take a V7, V9 lead, or you just see this ECG in the mirror, you will be able to see that there is an ST elevation in these two leads. Just on the page, on the back side, and you will be able to see the ST elevation. This is the sign of a true posterior wall Merkel infarction, which is there as a part of inferior wall MI or an association of inferior wall MI. Posterior wall MI is being presented in 15% of the STEMI. Isolated posterior wall MI is very rare. It is present only in 3 to 10% of the patient. But when it is being combined along with inferior wall MI, it is being presented in 70% of the patient. It is almost always remember one thing, that any case of acute MI or inferior wall MI requires a right-sided lead to diagnose whether the patient is having RVMI and get posterior leads to diagnose whether the patient is having a posterior wall MI or not. So these are the two indications by which you can diagnose inferior or anterior or RVMI with the help of this ECG. So in posterior wall MI, the depression will be there in V1 and V2 because the vector is going away, while the vector is going towards backside. That is the reason there will be elevation in V7, V8, and V9. And that is the reason the STEMI elevation will be there in posterior wall MI. So in V1, V3, you will be seeing the depression, but when you are seeing the mirror image, it will be having a ST elevation. And this is the ECG which is showing the posterior wall MI. In posterior wall MI, you will be seeing the R wave present in the V1 as well. R will be more than the S wave in V1, in V2. ST depression in V2 and V1, and upright T wave in V1, V2, V3. These are the signs which can give you the diagnosis of posterior wall MI. Our diagnosing this that as a non-ST elevation MI, it is a ST elevation MI because it is showing the posterior wall, and that is the reason the scapular leads V7, V8, and V9 requires to be taken. That will give us the idea about the posterior wall MI, which is having a ST elevation. All these things will require diagnosis in no time, because this will prevent a definite amount of uh, uh, further progression or adverse cardiovascular event. This is the V7 V8, which is showing ST elevation. Not only that, 0.5 millimeter of ST elevation in V7 V9 is required to make the diagnosis of posterior MI. So it's not that you require more than 1 millimeter, just 0.5 millimeter or half a square. Even that sort of ST elevation in V7, V9 will give you the diagnosis of posterior MI, and which can be diagnosed by putting a lead on the backside, that is on V7, V8, and V9. So it's a true extent of myocardial damage, which is inferior wall MI. In suspected isolated posterior wall MI, it confirms the presence of myocardial infarction. So STEMI equivalent are pre-existing LBBB or Garbosa's concordance, posterior wall MI, left main coronary occlusion, deep intersign, and hyperacute T wave changes, which are being diagnosed as a STEMI equivalent. So these are the things which are already been diagnosed and being thoroughly accepted by almost all the societies across the globe. So whenever we are talking about ECG, ER physician and cardiologists, they must widen their focus to include conditions which are linked to the need for aggressive reperfusion therapy. And that is the reason I think it is always better to look for all these cases where you can diagnose this condition in time and you can subject this patient to receive reperfusion therapy in time. Thank you very much for the quiet listen. Thank you so much.
So there are certain questions in the chat box.
Sure. Yeah, so Dr. Ramesh Mathur, yeah, he is from Indore. How ST elevation tracing will appear in patient with pacemaker device? So that is what I have shown, Dr. Ramesh, that if I can show you again the Garbosa's criteria of pace rhythm, I'll show it again. Yeah, this one. See, these are the guys, Garbosa's criteria. These are the pace rhythm. Here you can see that I'll put the laser. You see this? This type of pattern is being seen as a pace rhythm. And this Garbosa's criteria, you can diagnose that there is a ST elevation with a concordant pattern. In a pace rhythm, it will be having a discordant pattern. And in V1, V2, V3, it will be having a ST depression. Now I'll show you the pace rhythm ECG. I showed you the ECG of a pacemaker having a blip. Now this is the ECG. Can you see the blip? This is the blip. And then there is a ST elevation. There is a definite amount of ST elevation, which is more than 5 millimeter. Here you can see that V1, V2, and V3, it is having a ST depression, which is more than 1 millimeter. And these are the Garbosa's criteria, and they are going to get, diagnosed in patient having a pace rhythm. So this is how you can diagnose the ventricular pacing in an acute MI situation. I hope I've answered your question, Dr. Ramesh. Then Dr. Srivastava from Delhi, if ST depression more than 2 millimeter in more than 3 leads, then what does it infers? So it infers whenever there is a ST depression in more than 2 leads in 3 leads, more than 2 mm in 3 leads, it is suggestive of a development of some sort of ischemic pattern, but you must identify whether it is showing or it is being reciprocated in opposite leads as well or not. Because here you need to identify whether the patient is having ST elevation in the opposite leads or not. Otherwise, even a more than or equal to 2 millimeter of ST depression, it is showing the evidence of ischemia, provided you have ruled out any systemic cause of STG changes, either in form of hyperdynamic circulation, hyperthyroidism or thyrotoxicosis, anemia, or any condition which can lead to hyperdynamic circulation. Then Dr. Naval Kishore from Patna, what type of, just a minute, what type of ECG is present in left anterior hemiblock? Yeah, so left anterior hemiblock will be seen as a deep QS pattern in lead 2, 3, and AVF, positive QRS in 1 and AVL. There is a very short or a very small Q wave in lead 1 and AVL, and there is a very short R wave in lead 2, 3, and AVF. This is a sign of left anterior hemiblock or a fascicular block. Then comes Dr. J. Vishwanathan from Chennai. How to identify cardiac tamponade through ECG. ECG will definitely show electrical alternance pattern. You will, because the heart is floating inside the pericardial effusion, so you will be having a different axis. So one axis is showing a large complex, the other axis or the other bit is showing a smaller complex. One thing is very sure, in cardiac tamponade, you will be having a low voltage ECG, and it is showing a electrical alternance. So one is having a large QRS complex, the other bit is having a small QRS complex, but it is showing a different type of low voltage ECGs. How to identify hyperventilation through ECG? Now, hyperventilation, Dr. Pankaj, it's a very nice question. Hyperventilation will definitely produce a ECG changes which is similar to that of a early repolarization. It will show a concavity upwards of ST elevation, a J point elevation of less than 1 millimeter, and it is there as a part of global STD changes from V1 to V6, even in 1 AVL and 2, 3 AVF, which is showing a ST elevation in J point. And that could be, if one thing is very important, that whenever you see an ECG, you have to compare it or you have to correlate it along with the underlying history, because that is the way you will be able to diagnose the actual condition. Otherwise, there are ample of differential diagnosis by which you can diagnose from ECG. So I think I have answered almost all the questions.
Thank you so much, sir.
Any other suggestion or any other questions are there, I am ready to answer.
Perfect, sir. I think there are no more questions in the chat box, and it was certainly a very enlightening session. And to propose the word of thanks, I would take this privilege to invite President Corona Remedies, Dr. Vijay Charlu. So he will be proposing the vote of thanks. Over to sir.
Hi, sir.
Hi.
Namaste, sir. Came
Namaste, namaste. Good
So
evening.
it's I really thank you, sir. This is the first rhythm and wave workshop that we have done, and I've always known you. I mean, Dr. Jaysha is known as one of the pioneers in not only the way he does his angioplasties and cardiologist that he is acclaimed cardiologist, but also I think he is into a lot of education. And I've seen him do a lot of CPR work for patients, I mean, for the societies. And more than that, he has also contributed to the education of a lot of students across the country. And that's a privilege that I carry for him. And I would really thank him from the bottom of my heart. I've attended the entire show, sir. I mean,
Thank
I've
you
seen
so
all
much.
the ECG things.
Thank you so much
And for
for
me,
the
it's been a
opportunity.
real enlightenment. And I'm sure there are around 400, 450 doctors who are there online and who have
Wow.
attended this program. So it's really a good eye opener for them as well, sir. So on behalf of entire Corona Remedies, I thank you, sir, for having graced this and also giving a lot of your knowledge domain to people so that they can actually read the basic facts of ECG and the complicated facts of ECG. So thanks, sir, and looking
Thank you
forward
so much.
to further more rhythm and wave. But
Absolutely.
you are the person who became our Sachin Tendulkar, as you always are.
It's my pleasure and privilege, and I'm really
Thanks.
honored. Thank you so
Thanks,
much.
sir. Thanks a lot. Thank you. Have a
Thank you.
wonderful evening ahead, sir. Thank you.
Same to you. Same to you. Thank you.
Yeah.
Okay, sir. Thank you.
Thank you.